My name is David Riley. I'm the Communications Director for Cape Cod Healthcare. And welcome to all the members of the media here in attendance this morning. We appreciate the good turnout for today's program. Most of you have already met and spoken with Dr. Saluzzo. Also here today we have our Chairman of the Board of Trustees, Bob Birmingham, Dr. Jim Butterick, the Medical Director for Cape Cod Hospital, Dr. Dan Comber, the Medical Director for Falmouth Hospital. I also have press packets here, if anyone hasn't received them yet, and we'll be releasing a press release as well at the conclusion of the program. So at this point now, I'd like to turn the program over to Bob Birmingham, the Chairman of the Board of Trustees.
Thanks very much, David, and good morning. I just want to make a couple of points here and then let Dr. Saluzzo get into his financial program for Cape Cod Healthcare. Number one, I think it's important to recognize that the doctors and nurses and staff of both the Falmouth Hospital and Cape Cod Hospital do a tremendous job in delivering a very, very high quality service to this community. I think we may have been a little remiss in not letting the community know just how good it is. These people do a great job day in, day out, and that's not going to change after today's announcement. Several months ago, the board took on the duty and responsibility of finding a replacement, a successor to Steve Abbott when he announced his retirement. And we think we found the best healthcare executive available to serve this community. Dr. Saluzzo has certainly seen this movie before, so to speak. He understands the industry and he understands what it takes to bring us back to a financially stable position. The healthcare industry is in a lot of trouble. I don't think that's a surprise to anybody. There's a lot of things going on that on a national level that is not something we can correct, but there is a number of things that we can do locally here to change the picture and to preserve and protect Falmouth and Cape Cod Hospital for this community. That's exactly what we're going to do. So without further comment, I'd like Dr. Saluzzo to come up.
Thank you, Bob. Before I make a few comments, I just want to remind you in your packet there are a lot of data points that will outline in more detail some of the things that I'll touch upon and give you a fairly good picture of what we're doing. I was here not too long ago at a happy occasion, the announcement of my hiring, and obviously today is not one of those occasions. As you know, we've had significant financial challenges. In fact, as I was interviewing, things kept getting worse and worse, so it was a moving target even for me during that process. What we know is that it's going to take courage and leadership to fix this. And we do think we have the right people to do that. We have now medical staff leadership groups at each hospital, and that doesn't exclude our nursing and our nurse practitioners and others, but the physicians are meeting with the board and administration. We think we have the community behind us. We have the unions that we're meeting with. We want them to join in this. We basically want the whole Cape to align and do anything they can to make our health system as good as it can possibly be. First and foremost, before I talk about our program, I want to emphasize that patient care and safety is our overarching concern. Has always been my personal overarching concern in any situation I've been in. Wherever we've had to turn around or we've had tough financial times, we've stuck to that script, and not only because it's the right thing to do, because frankly it will lead you to the efficiency and the quality and the consistency that you need to be successful financially. We have a strong reputation for excellence, and in your handouts you'll see some of those markers. Cardiac surgery, we've done 1,024 cases with a 1.8% mortality, which exceeds the national mortality level and exceeds, frankly, some of the large systems in Boston. So you've had excellent care on the Cape. The acute myocardial infarction or heart attack morbidity and mortality has been among the best 17 healthcare systems in the country. Our infection rates in terms of ventilator-acquired pneumonias and central line infections have been 0 for 16 months, no infections. And our service is in the top 10% of hospitals in the country, over 1,800 hospitals, on our nationally benchmarked customer satisfaction survey. So an awful lot of quality here, and also awful lot of building blocks of excellence in the Cape Cod healthcare system. This year we're going to join the Safest Hospital Alliance, which defines even more specifically how to get to desired outcomes in healthcare. And we intend to make an already safe, high quality, high service system even more impressive and better defined in those areas. That the key to all of our changes will be process improvements, making processes work better so that you can become more efficient at processes, and each person working more efficiently can accomplish more with less rather than accomplishing less with more, as you do when you have inefficient process. Despite our excellent service and safety record, we do have a $25 million operating loss at this point in time and a $15 million net income loss, which is the operating loss, and then you add in your proceeds from your portfolio, your investment portfolio. Despite the addition of those proceeds, we still remain in red ink at net income. The present financial performance is not sustainable. We're not alone in the state or the nation in these struggles. When I left Tennessee, 75% of hospitals were losing money on operations. In 2007 in Massachusetts, only 20% of hospitals were losing money in operations. That number has grown to over a majority of the hospitals are losing money in operations, and almost 40% now at the net income level versus 10% in 2007. So dramatic changes in the state's healthcare economics affecting hospitals. So the question is, what do we do? And we believe the answer lies in our board, administration, physician leadership groups, staff, unions, and the community working together to rectify this situation. As a part of our plan, it's our fiduciary responsibility to ensure that we have appropriate staffing levels throughout the organization. In fiscal year 2004, as an example, Cape Cod Healthcare had 21,521 admissions, and that's in your packet. In fiscal year 2008 annualized, of course our year ends September 30th, we will have 20,913 admissions, which is 600 less than 2004, our index year. Yet we have 130 more employees than 2004, and in fact we have 170 more employees than 2003, which had similar volumes as 2004. Our bottom line improvements, our plan calls for $30 to $40 million in improvement, and it will come from revenue expansion and expense reduction. The details of the plan are outlined in the fact sheet. A few of the highlights: half of our improvements will be coming from revenue enhancement. So this is not a shrink to greatness plan. There are elements of expense reduction, of course. We need to become more effective in our financial processes, including physician-patient billing and coding. On the expense side, we're looking at reducing consulting fees, legal fees, other non-personnel fees, and they will result in significant savings for us. Our plan is to reduce expenses as noted, including reductions in our workforce. Today we are announcing a reduction in our workforce of 169 people. Obviously, this is the most painful part of our expense reduction program. We consider every one of our employee partners to be an important contributor to the success we've experienced at Cape Cod Healthcare. There's no one on our board, management team, staff, or in the community, I would imagine, who want to see reductions of this nature, especially not your CEO. We will treat each and every person with respect and dignity and offer them the maximum support possible in order that they may find career alternatives. We will provide each employee affected with outplacement services. We've contacted with Transitional Solutions of Boston to provide resume writing, job placement, counseling services for some of our team members, and we'll be working with the Career Center of the Workforce Investment Board in Barnstable on support for others in our workforce. We will obviously provide appropriate severance packages for eligible employees, In short, we'll offer any support we can, and this, of course, comes from the board, upper management, through the ranks. These are all of our partners and colleagues, and we want to see the best for them. As I mentioned earlier, patient care and safety remain our top criteria, and the board has asked that we measure in a continuing way the impact on any safety or quality issues from these reductions. Our goal is to become safer and better in every way, not to take a step back. In fact, this plan calls for a minimal number of reductions in the clinical area. There are only 7 RNs in this program that you're hearing about today. This reduction should result in a savings of about $13 million in our operating costs. And the discussions with the affected employees are taking place in the early part of this week and may not be entirely completed until midweek. So we'll try not to get into any specific detail today with you for that reason, out of respect for those workers. In an overall way, and it's in your packet, there are about 33 manager positions being reduced, 15 of which are corporate. We did not spare corporate in this approach. 18 are in the hospital. We have 36 non-union, non-manager positions, 87 union positions, and 13 folks who've taken early retirement. 91 of the staff that are being reduced are at Cape Cod, 27 at Falmouth, and 51 in corporate and other areas of the health system. Just a note quickly on the hospitals program, which received more than a little bit of ink this week. We are in the process of working out a new plan with our medical staff leadership, the hospitalists, to make our present program more cost effective, but just as effective clinically. We have a tremendous group of hospitalists, and we certainly want to work effectively with them and medical staff leadership to have the best hospitals program possible. This weekend I rounded both at Falmouth and here and saw firsthand with the hospitals and saw firsthand the great care that we deliver. And that's not going to change. My wife actually had surgery here Thursday at Falmouth Hospital, and the care was superb. So I understand what's going on in the hospitals. I see processes that can be improved, but I also see outstanding people who make extraordinary efforts to make patients more comfortable and give compassionate, safe, high-quality care. And that commitment, I think, starts at the ground level, so it won't be hard to continue it at the top level. So in summary, Cape Cod Healthcare is the Cape's largest employer. We understand the impact of our announcement today. We know it's a difficult time for the people involved. It's a painful step for everyone from the board, chair, to the colleagues that work with these folks, but a necessary step in preserving and building upon the Cape's most important health care resource. We will provide each employee, as mentioned, with outpatient placement services. We will provide severance packages where appropriate, and we are looking for everyone on the Cape to pull together to get by this period of difficulty, really, in our history. Right now, I guess we will be willing to take questions, myself, Mr. Birmingham, the management team, and others in the room as necessary. Yes?
Could you tell me who was involved in making decisions about where the cuts would occur?
The team was, well, obviously I was involved, but the management team, down to a level below the executive level, was involved. It was ratified by the board after a fairly lengthy discussion. So it was done, I think, according to benchmarks. We used a lot of national standards, and of course the internal benchmarks that I referred to earlier. Where we were in 2004, we were a top 100 hospital with the fewer employees. So clearly we were not worried about safety then. In fact, we were very safe, and there's no reason to worry about it now.
Was there any input from the union? Or?
I would say not specifically. Yes?
The fall-off in 1 year has been precipitous. What do you see as the trend moving forward? Is this just staunching something that's only going to accelerate nationally and locally, or do you see other actions that you're going to have to take to keep up with the trend line?
Well, I do think nationally our reimbursement system is in trouble, and I do think, as you quoted me in the paper, I do think 10 to 20% of hospitals run the risk of closing over the next 2 to 3 years if something doesn't change. So it's not a blip in the radar screen. This health system never lost money until '07, and that was just on operations. But this is not just a blip on the radar screen, and many, many hospitals are going to have many hard decisions to make over the next 2 to 3 years.
Is there anything specifically that you can point to this precipitous change from +2 million to -25 million? Or would it be just the perfect storm of a lot of things coming together?
Well, I think it is the perfect storm that accelerates over a short period of time, and that perfect storm includes a recession, a severe physician shortage, supply and demand, so you have to literally pay more to get physician services, an aging medical staff. So emergency department coverage, as an example, becomes a huge issue. As you get older, you just don't want that in terms of quality of life. Lack of growth on the Cape. You did go through some growth not too many years ago. You're flattening out in your growth. Ever increasing Medicare population. 25% of the Cape is older than 65. The national average is 12%. Medicare is not a particularly good reimburser. So I think those are some of the highlights of the things that have led to a precipitous fall in revenue.
Would this be the largest cutback ever in the history of the hospital? Do you have any historical reference?
I haven't looked up each and every year since the 60s when the hospitals formed individually and then came together. My guess is this would be the largest. Yes.
Can you relate the bottom line improvement list with the next page, which is expense reductions? The bottom line improvements indicate a total of 15 million, but it doesn't necessarily reconcile with the following page. So I just want to be sure when I walk out of here I understand.
I'm not sure I have that page. If you bring it up to me, I will do it right with you.
And then it's the subsequent page. Just want to be sure.
I understand.
It's all reconciled.
Okay, so the bottom line improvements are actually just on the revenue side, and they're conservative. We're hoping 15 to 25 million on the revenue side. So you're just seeing essentially revenue there. There is one cost reduction item to legal and consulting, but essentially this is your revenue enhancement list. The next page is the expense reductions. So the two together are 31 million to 40 million.
Thank you.
Other questions? Yes.
You say the reimbursement system, did you say it's broke or in severe need of modification or revision?
Something that's in need of severe modification is broken usually, so I say it's semantical. I think it's severely broken and unsalvageable. 17% of our gross national product is going for healthcare, 4% for the military, and we're in 2 wars. Yes.
Is there anything in the cost reduction plan that would have to do with outsourcing jobs that had been done by employees?
No. I mean, that is something that, from a business perspective, with union input, et cetera, and collaboration, we'd consider as we go forward, because sometimes we're not good at everything. Managing office buildings, for instance, is not one of our strengths necessarily. So that's an ongoing dialogue.
You said you hadn't talked to the union, or the union hadn't had major input in the cut. Do you expect any kickback from them?
You know, I'm only here a month, and I'm probably not as versed in union culture and psychology as many of you. My guess is when there's a perception that something's being taken away, whether it be jobs, salary benefits, etc., there's that opportunity to have that kickback. I'm hoping that we'll minimize it, because I think everyone in the room shares the same desire for high quality health care and to create as many jobs as we can on the Cape. We all have the same goals. None of us will be served well if we go into a GM like General Motors like spiral and end up doing worse things. So we're trying to act in a responsible way at the right time, not wait too long, and do the right thing so the corpus benefits and the community benefits. Yes?
Systemically and long term, do you anticipate that there has to be more consolidation, however it is structured with Boston hospitals, or a more regional approach?
Well, we do work a lot with Boston now, and I think if the reimbursement system changes and went to a cost-plus system, that wouldn't be necessary. If we went to a single payer based on cost-plus, for instance. If the reimbursement system doesn't change, I think you're going to see a radical transformation of healthcare that could include a scenario that you just described. I don't really believe there's enough strong hospitals in the country to bail out the weaker ones at the end of the day. And I do think, as I said, we're going to see 10 to 20% of hospitals in the position of closing, and I don't think there's enough beds to go around that will be a good thing. That would be a very bad thing as we age.
How about dealing with the so-called niche providers in the competition? Some of them have come in from outside. Others, there are other situations where the hospital program has taken over or included services, such as hospitals, things like that.
Yeah. You can't really recruit primary care docs any longer without a hospitalist program. They don't want to go back and forth from the office to the hospital, so that's a given in our new healthcare environment. In terms of niche, like surgery centers and things of that nature, I think we've got to find a way to work with the docs, which we're trying to do through these medical staff leadership groups to partner. I don't think there's going to be exclusivity on a product line going forward. Yes, Cindy?
Do you think in the long run, a single payer is the way to go?
I do.
Why do you think that?
There's, just look at all the nations that have 8% of their gross national product. They're all single payers, and they have better outcomes, better physician satisfaction, better customer satisfaction than us, and their patients are just as sick. You see very few, you see no nations modeling their systems on ours. When you look at third world nations with emerging healthcare systems, they don't even peak at ours. So healthcare is not a birthright in America. It's a byproduct of economic process. And philosophically, is that what we want? Any other questions? If not, you can pull one or two of us aside, and we'll be glad to talk to you. Thank you for coming. Appreciate it.